Good morning, everyone. I'll be presenting on not just salt and water on behalf of Medicine 2. Mrs. S, a 36-year-old woman from Parnambat, presented with complaints of breathlessness for 1 month, which was insidious in onset, was progressively worsening. Orthopnea was present. She was complaining of poor sleep and was unable to sleep, with recent worsening over the past 1 week. Her effort tolerance had significantly reduced from being able to walk over a kilometer to breathlessness at rest, NYHA class 4. She also had bilateral lower limb swelling, which she noticed developing over the past 1 week. The swelling was present up to the knees, was associated with mild facial puffiness. There's no history of decreased urine output. There is no history of angina, no past history of diabetes, hypertension, or smoking, no history of fleeting joint pains, skin rashes with fever in childhood, no history of cyanosis or unexplained exercise intolerance in childhood, no preceding viral illnesses, no past history of TB. There's no photosensitivity, joint pains, skin thickening, or frothy urination. There's no history of any addictions, no history of any alternative medication intake. There's no history of sudden cardiac death in the family. She's P3 L3 with last childbirth in 2012. Her past history wise, she had a significant past history of an anterior midline neck swelling, for which she had undergone surgical removal of the same a year ago. 2 weeks post the surgery, she began developing numbness involving both her upper and lower limbs, which was transient and recurrent, and was associated with perioral tingling sensation and twitching of eyelids. She regularly took IV medications for these symptoms once every 10 to 15 days from a nearby clinic, after which she says that her symptoms improved transiently. However, her symptoms kept recurring and was present even at her current presentation to our center. On examination, her heart rate was 110 beats per minute with a hypokinetic pulse. Respiratory rate was 24 breaths per minute. Temperature was 97.4 Fahrenheit. Blood pressure was 90 by 60 millimeters of mercury. She had an anterior neck horizontal scar 1 centimeter above the sternal notch. Bilateral pitting pedal edema up to the upper 1/3 of the legs was present. JVP was elevated to 3 centimeters above the sternal angle. There was no icterus, cyanosis, clubbing, or lymphadenopathy. On examination of the cardiovascular system, the apex was felt in the left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line, and was hyperdynamic in character. S3 gallop was heard. S1 and S2 was heard normally. There were no murmurs. Respiratory system examination, she was in respiratory distress, was using her accessory muscles of respiration, and she had bilateral infrascapular and infraaxillary inspiratory crepitations. Per abdominal examination, there was no free fluid, there was no liver or spleen that was palpable. CNS examination there were no gross focal neurological deficits. Her ankle reflex was not elicited. She had gross pedal edema. Any other examination that you would like to do in her case? Anyone wants to volunteer? Yeah. So in her, Trousseau sign was positive, Schwarzeneg's was negative. Sorry.
Anything else?
Her symptom complex was that of dyspnea with pedal edema, with tachycardia and tachypnea at presentation, and elevated JVP with bilateral pitting pedal edema and an outwardly shifted hyperdynamic apex with an S3 gallop and bilateral basal crepitations, which pointed to an acute decompensated heart failure. And in the history of a probable thyroidectomy that she's undergone, with symptoms suggestive of hypocalcemia and a positive Trousseau sign, iatrogenic hypoparathyroidism was considered. The differential diagnosis for her presentation that were also considered were cardiovascular causes such as ischemic heart disease, structural heart disease, hypertension, inflammatory causes, both infective, non-infective, metabolic causes such as thyroid, parathyroid disorders, diabetes, calcium, phosphorus, and magnesium deficiencies, nutritional causes, and familial causes. This was her ECG when she presented to ED. Does anyone want to volunteer what the abnormal finding is?
You want to start with the first years and move on to the final years? Have a go.
um, sinus rhythm with the rate of around 100 and 120, I think. And I'm looking at if every QR is presented by a P wave.
Everyone can make mistakes. Sorry.
Check. U waves are present and QT segment is prolonged.
Yes. Yes. The patient has significant QTC prolongation with the T wave almost overlapping with the P waves. Her QTC at presentation was 567 milliseconds. Her investigations showed that she had mild anemia, which was microcytic hypochromic, with iron studies showing iron deficiency. She had her total counts were 17,700, platelet counts were 5,55,000. Her serum electrolytes, sodium, potassium, and bicarbonate were within the normal limits. Urea and creat were normal. Liver function test was normal. Her CKMB troponin showed no serial elevation. NT-pro-BNP was elevated to 6,191 picogram per ml. HbA1c showed that she was pre-diabetic with 6.4 grams percentage of a value of 6.4. Her calcium at presentation was 4.17, with corrected calcium being only 4.33, with phosphorus being elevated to 7.3 milligrams per deciliter. Her vitamin D was normal, 33.1, and PTH was very low, less than 5. Magnesium was 1.63. TSH, T4 FTC, she was on supplements and was normal. Thyroid antibodies were within normal limits. Other workup showed ANA negative, dsDNA was normal. Complements were within the normal limits. RF and ACE were also normal. Her chest X-ray showed features of cardiomegaly, and there were bilateral pulmonary edema was present. Echo showed LV systolic dysfunction with ejection fraction of only 45.5%, with grade 1 LV diastolic dysfunction and normal RV function. There was global LV hypokinesia. Cardiac MRI was performed to rule out other infiltrative disorders which can also present with a dilated cardiomyopathy. It showed a non-ischemic dilated cardiomyopathy with LV systolic dysfunction. There was no myocardial edema. There was no evidence of myocardial infiltration on the MRI. So we ruled out the other causes. The differentials that we had currently was we could not definitely rule out an infectious or a viral myocarditis which could have led to a dilated cardiomyopathy. Autoimmune inflammatory causes were ruled out. There was no history, as well as the biochemical parameters was normal. The structural heart disease was ruled out. Echo and clinically, as well as echo findings were normal. There was no definite history of drug or toxin intake. Her last childbirth was 12 years ago, ruling out pregnancy-associated dilated cardiomyopathy. Familial restrictive, there is familial history or history of TB was not there, and her ECG that was done serially did not show any other rhythm abnormalities. The thought process that we had at this point in time was whether she had a PTH-dependent hypocalcemia, which resulted in a dilated cardiomyopathy. On review of literature, this a narrative review of about 12 cases was described of dilated cardiomyopathy, which was secondary to hypoparathyroidism. All of them described similar features of presentation with patients presenting in dyspnea, with orthopnea, with features of pulmonary edema, with ECG changes showing prolonged QTC. And the mechanism behind calcium metabolism resulting in cardiomyopathy is that though there is intramyocyte calcium stores are adequate, serum calcium is essential to stimulate the L-type calcium channels to cause calcium release, that is the calcium-induced calcium release for adequate myocardial contractility. The management of patients with dilated cardiomyopathy as a result of hypocalcemia would mainly be to correct the hypocalcemia, and also to keep in mind that diuretics that we use, loop diuretics, cause calciuria and can further cause hypocalcemia, and thereby to, once the acute phase is managed, to supplement them on thiazide diuretics. Chronic hypocalcemia can be managed with oral calcium and vitamin D supplements. The course of our patient in the ward, she required NORAD support and was on NORAD and Lasix infusion. As she had the cold and wet phenotype, she was started on goal-directed therapy for heart failure. She was later switched to thiazide diuretics, and she was managed for hypocalcemia with parenteral calcium supplementation, and she was discharged with oral calcium supplements. At discharge, her QTC had improved to 470 milliseconds. Thank you. Learning points here were hypocalcemia is a reversible cause of dilated cardiomyopathy, management of hypocalcemia, and management of heart failure in hypocalcemia, the preferential use of thiazide over loop diuretics. Thank you.
Thank you, Hamsa. That was such an interesting presentation. That history of surgery is something that, and the cramps is something that she already told you, or you elicited?
She told.
She
ma'am.
told.
Yes,
Okay, so
ma'am.
it was quite forthcoming. How frequent is hypoparathyroidism outside of the surgery? Very rare. So the usual cause for hypoparathyroidism is only with a thyroidectomy. Where was the surgery done?
It was done at a local center near Parnam, but Arcot, she said.
Very interesting. Okay. I've never seen a hypocalcemia induced cardiac failure. Any other thoughts or comments from the faculty? Whoever managed, did you have any other insights that you wanted to share? Reba? Did she manage?
Yeah.
Was it your patient?
Yes, it was.
Okay.
I mean, this patient was very interesting in the sense that she had a definite temporal association. She had the classical symptoms of hypocalcemia, and then all the heart failure symptoms had only chronic hypocalcemia. And the interesting thing is it's quite reversible. If you look at case reports, they've ruled out viral myocarditis by actually doing an endomyocardial biopsy. That's one of the last further investigations we can do for her. But because of all the finance and cost constraints, we've not proceeded with that. So we can actually follow her up in 3 months and see how the resolution of the symptoms are.
Yeah, just interestingly, one of Ritish's thesis was 5-year retrospective review of patients with non-ischemic heart failure in Department of Medicine. But interestingly, we didn't find any with such an etiology. So it appears that not been seen in medicine, at least in the last 5-6 years.
So the primary hypoparathyroidism is one of the rarer endocrine problems. So only the iatrogenic, and I think iatrogenic here within the institution, we won't see because I think they preserve the parathyroids and they manage the hypocalcemia post-op pretty well, I guess. That's probably what it is. And very good, Nishit, on picking that up. So don't be scared of answering. No? Sure. Fantastic. Thank you very much, Hamsa. Anything else that you'd like to add? Amit?
I just have a comment. Hamsa used the word PTH dependent hypocalcemia while describing the hypocalcemia. I don't think that's a word.
It's not.
So there can be PTH dependent hyper or PTH independent hypercalcemia.
Okay.
When you talk about hypocalcemia, you talk in terms of whether it is PTH deficient, PTH ineffective, or PTH surplus, right? PTH cannot be, I mean, hypo cannot be dependent on PTH.
Okay.
I was looking at that slide. Thank you very much for pointing that out. You're right.
Thank you. Thank you, sir.
Sure.
Thank
We'll
you.
move on to the Joe.